I'll straight away turn it over to Lenny.
Thank you, Diane. So the first order of business, just the main task for today, is to look at the communication strategy document that was circulated and beef that up. And we have a small number here, so we're going to have a lot of authority vested in a small group. Then Diane has put together an outline for the final report, so we'll be talking about that. So, but before that, we just need to approve the minutes from the May 29th meeting. Did anybody have any comments on those? With thanks to Tiffany for preparing them. Seeing no comment, no
Great.
changes. Good. Okay. Then let me turn it over to Diane. She's going to talk about two areas. One, an update on the regional transformation partnership grants, and then also talk about the work of the performance measurement work group and some new measures that I think are germane to our work. So.
Thanks, Lenny. First, I'll review a PowerPoint presentation, an excerpt from what was presented at the regional partnerships meeting last week in a webinar. And as you know, the regional partnerships are hospital-focused grants for planning care coordination projects. So the topic of this presentation was around measurement and what areas of measures the grantee should consider as they put together their project plans. The regional partnerships, because they need to have goals, the only way you can measure whether goals are achieved is if you have measures that apply to those goals. So that's just the point of this slide here. Year one is, we're shifting to consumer-centric, improved care transitions, payment reform, and then we're looking right now under the model in general, care improvements, integration, infrastructure development to support a direction of the model, and then in year three next year, the focus is on implementing the infrastructure workflows, the various workflows and models that the grantees are going to develop and put in place, and then to, as integral to that, to engage patients and families. The final report template, this is really small, and I'm sorry. Sorry, I should have tried to blow it up. I just literally stole the slides from what was presented to the grantees last week. But the template will have to put the goals, strategies, and outcomes. So here's an example. Well, it's not really an example. It's defining, articulate your goal, describe your target population, describe the specific metrics that you're going to use, and then actually state how you're doing on the metric. And I believe that within the planning context of these partnerships, we would ask them to provide, as they develop these metrics, what baseline data they want to share so they can see how changes occur over time and what trends are occurring in the metrics. And we've just been joined by Suzanne Schlappman. Thank you, Suzanne. Great to see you. Hopefully got ahead of the raindrops. The next slide addresses the issue of performance measurement and what sorts of measures and I guess what is the limited universe of measures that the partnership grantees are encouraged to select from. So we would want them to select validated, reliable, in-use, developed measures, as opposed to do that first, as opposed to going through a wholesale development of a measure that may not have been validated or been demonstrated to be reliable. So these could be process of care, cost, quality, patient satisfaction, and other measures of health or population health. And then there's a need to define the target population. Is it at the regional level? Is it at the hospital level? Is there a geographic catchment area? And then adapt what measures they want to measure to that population. So there, we envision a core set and then a plan, a partnership plan specific set. So the core will be what we expect all of the grantees to collect, and then the plan specific will be based on the target populations and how they've defined their projects. And then within there needs to be a little flexibility. If there is a measure that they believe is valid and reliable and important and feasible, then we would encourage the grantees to select one or two measures that are new if that's what they need to do to demonstrate the effectiveness of their program. So we have we got a lot of measures. We got hundreds of measures that we're collecting on hospitals, and Novella Tasco's just joined us in the room. Thanks, Novella. Good to see you. Among the universe of measures that we are already measuring and reporting this first set to Centers for Medicare and Medicaid Innovation are the Maryland contract model measures. We do have what we call a GBR infrastructure report, and I don't have the details of all this in front of you. Hello, Linda Adori's just joined us in the room. Welcome, Linda. Thank you. No, great to have you. The GBR infrastructure says, what are you doing with the extra infrastructure money for your global budgets? Because we did give hospitals a small, about 0.5% of money in their global budget in order to develop an infrastructure to do better implementation of targeted patient interventions beyond the hospital walls. Be a little bit more global thinking and do things like care coordination. So it's a similar effort. It is an effort rowing in the same direction as the partnerships, the GBR money. So we do have an infrastructure report. What did you do with the money and what happened with it? So, and we can share all of these detailed reports with this group. It's just for purposes today, I want you to be aware of all the stuff that's being collected. There are 50 or 60 measures on the monitoring contract, the GBR infrastructure report. There's a lot of structural kinds of things and a lot of narrative, kind of descriptive, as opposed to quantitative information. And then there's a total cost of care report that we are developing that when we're in our more advanced model after this first phase, we will want to calculate the total cost of care and demonstrate a trend line that isn't wildly out of control with that, and it is in line with the lower cost goal of the three-part aim. There is a CMS ACO measure list, and those tend to be outpatient. Those are accountable care organizations. There's various ones in Maryland, and they're on the hook to collect these measures, and I believe we have some samples of those in these slides, in a couple slides. And then there's other validated quality measures. You can go to the ARC. They have a measures clearinghouse, AHRQ. There's the NQF has a list of all of their endorsed measures. The value of using NQF endorsed measures is that from a regulatory standpoint at the federal government level, if a measure is endorsed by NQF, it is a proxy for the government to have to develop its own standard, because it's an independent body that has the complement of stakeholders that are needed to vet and endorse measures. It stands in for what the government would have to do to develop a measure. So that's why CMS tends towards selecting NQF endorsed measures. We, on the other hand, are not bound to that in selecting state-based measures, but the NQF measures warehouse is vast and has lots of lots of documentation in it about the various measures that have been endorsed. And then, you know, we get to these program-specific or unique measures that may be one or two newly developed if that needs to happen. So here's this total cost of care. We got here in Maryland what we call regulated and unregulated services under the model. So we'd need to understand all of the care costs that go into a patient's care. So, so you see the list of things on the regulated side, and then the unregulated side is the continuum of care, the SNF, the home health, the other kinds of services that all go into what is that total cost. And so this is under development now, and we would be able to derive this from Medicare claims, but we would also ask what the partnership grantees are being asked to consider whether they can have access to the data that also gives this total cost of care picture. The ACO measures, again, are developed for the ACO community, and they also want to look at improved quality and decreased cost. And they are both, I believe they're claims and non-claims based. Here's the URL to find them, and here's some of the measures on the next slide. So the patient caregiver experience, ACO measure number 6, which I think is a very interesting measure, is shared decision making. And the definitions of these measures, how you define the numerators and denominators, and who's in and who's out, and how you meet that criteria, that's clearly a process measure. And I think it's a really good measure, and it's probably highly specified. So I think it's a nice one for consumer engagement, in my view, as well. So health and functional status is ACO number 7. Risk standardize all conditions readmissions. Number 8, we do a very close version of that here for Maryland hospital readmission. Ambulatory sensitive condition admissions, and they're focusing on COPD, respiratory disease, COPD and asthma, and older adults. We look at what we call the ARC version of these prevention quality indicators that are ambulatory sensitive condition admission measures, but they're much broader than these two respiratory measures. Medication reconciliation, we've had a lot of talk about that in the forums that Healthcare for All is running, and in this group, it's been an important issue. Falls, screening for risk, influenza immunization, pneumococcal vaccine, tobacco use, assessment and cessation intervention, depression screening, percent of with diabetes with A1C poor control, so that would imply integration with laboratory data, and then the ACO physicians their physician groups would need to report that as it's specified here. And then percent of patients with vascular disease who use aspirin or other antithrombotic therapy. Yes, Kim?
Just a quick question. Are all the ACOs going to be using the same measures?
They have a core set that they have to use. Okay.
All right. And if we wanted to see what some of these measures were?
Yeah, what you could do is click on that link on the previous slide, and it would take you to so here's the issue. The measure stewards, because measure development is literally a science, and it really needs to go through a process of a definition and testing and validation and reliability, phase validity, et cetera. And then you have to look at things like if it's observed, if there's inter-rater reliability. There's so much work that goes in before it sort of is cooked to be a mature and ready to use measure. The measure stewards need to be on top of where the measures reside in the cyber world, and so we would always defer to the measure stewards. And we've just been joined by Gary Vogan. Thank you, Gary. No worries. Thank you. Besides our group, we have Karen Ann Lichtenstein and Hillary Sumba on the phone. Right? Okay, great. So yeah, I think it would. I would imagine some of these measures would be of high interest to the group, and so if we want to pull some of these to the table of ones that we have interest in from a consumer engagement standpoint, I think that these are good, you know, ripe candidates, if you will. Okay, so these slides show how I mentioned the ARC measures that we use are similar but not exactly the same, that ambulatory sensitive condition measure. So this is just showing you the definitions and why the measure stewards, the developers of these measures, need to be on top of how they're defined, because there's nuanced differences between them. So I could read through the ACO version and the PQI version. Yeah, there's slight differences in these two measures. So, and these are related to diabetes. The ACO number 27 and PQI number 14. The PQI is the ARC version, and that again is Prevention Quality Indicator. And then they both have NQF assigned numbers because they've both been endorsed by the NQF. So as we think about how we want to apply, how the partnerships might apply these measures, they need to really select the right measures, not reinvent the wheel, which I've kind of implied already in this conversation, and then select, hopefully, from the universe of already existing measures. And what I didn't talk about is all the ones that we're already collecting for our quality programs, which we've learned about in earlier meetings, which are our quality-based reimbursement measures, which looks at inpatient mortality, some infection-type measures. We measure hospital complications, 65 of them that occur in the hospital and were not present on admission, and we also look at improvements in readmission rates, all-cause 30-day readmission rates to any hospital. And so conceivably, they might want to move the needle more on one of those measures that we're already using for the hospital program. So that's among the universe as well, just not in these slides because these are new. So some basic high-level metrics are fundamental to the all-new payer model and the goals of the regional partnerships. They need to be recommending core outcome measures, core process measures, and core savings measures. Those are the domains, if you will, of measurement. Okay, here's some recommendations for the core measures for the regional partnerships. And you'll see the list: total hospital cost, admits per capita, cost per person, healthcare cost per person. So it's a capita and person metric on cost, readmission, potentially avoidable utilization, and that's another whole domain of measurement that we do that looks at the costs of all these potentially avoidable encounters with the system. And then they may look at some composites of quality measures that are out there that are yet to be defined. And then, of course, patient experience, which is HCAHPS. And then there are other measures of patient experience that we'll also talk about in a minute. So here are some process measures that the measures on the top were outcomes. The measures below, these are process. So do they use the CRISP encounter notification system? Do they complete health risk assessments? And this is for targeted population, or what we call high utilizers. Establish longitudinal care plans, shared care profile among the providers that need to have that care profile, and the portion of the target population with contact from an assigned care manager. So those are some of the process measures.
High utilizers, do they have a definition that applies to this?
Yes, so there are, we defined in the partnership process 3 or more encounters. And there's like Excel data and stuff that we put out there from our case mix data to show what that looks like in various geographic areas. And then within that, so they would do the high utilizer set and also the target population set. So you get a sense of, well, how much is this intervention that the partnership is working on moving the needle for the high utilizer set, and then within that, the target population that they've defined. So we want them to measure both. And then, yes, the contact with the care manager there. Here's a recommended core cost savings measures for regional partnership, and this is return on investment, and it goes through a little calculation set of steps. I'm not gonna. Gary's smarter than me on this, so I'll let him read it, and then if there's some issue or concern, we can connect you with Shule or others who developed a sort of a template for this that's sort of a proposed approach. And there's resources out there for the regional partnerships, because if you can't measure it and have the resources to do it, then it's not feasible. So and we expect them to use a combination of data sources. Some will have to be developed and produced by the partnerships themselves, or sort of shaped or morphed from data sets that already exist, like the CRISP data. And so these include DHMH is a data source, HSCRC, CRISP, and then we'll present, if anyone's interested, what that inventory of data sources is on the July 9th, the webinar that we're going to have for the partnership. And then regional partnerships is this July 9 next step for the data resources, and then the 23rd is another sort of extension of, I think, data, which is what the CRISP Health Information Exchange has to offer, what an inventory or activities list, tools to support transformation, and some templates for care profiles and health risk assessments. So that's going to be on the 23rd. And then there is going to be a report inventory in progress to be posted. In other words, what we have already out there, the universe of reports that are already produced.
So, Diane, the time frame for the regional partnerships developing these, will there be anything in their preliminary reports that addresses the measures?
I think they have to propose some measures and then give us some baseline data by the end of the year. But I want to make sure that that's an accurate statement. I believe it's toward the end of the year. The later fall is the target time frame, or is it December? Yes. You want to turn that?
So there's a preliminary report due September 1, and then the final report's due December 1.
Right, okay. So I'm not sure of the delineation of what's due in which report, but I think that if they were going to have to come up with some hardcore data, it would be for the December report. They're probably going to propose what they want, what they're thinking about in September, and then actually produce some baseline data by December. Does that make sense?
Okay. Yeah, so I guess I was really just wondering if in the September report we'd see what the measures they were going to be looking at. That they hadn't gotten to that stage.
I think so.
Yeah.
I think there is an expectation they'll have some ideas about that. And then I think whether we want to, in this group, consider a recommendation, Linda's going to talk in a second, want to consider a recommendation about what we know, and if you all want to look at underneath the hood, as I said earlier, on some of these, and suggest what things might be of interest or of import to particularly consumer engagement, that's a good area to think about recommending something, I think. Yes?
Yeah.
Okay.
Hi, I just had a question. Thank you so much, actually, for all this information and the way you explained it. It was really clear from a health literacy perspective. who knows nothing about this, and I'm sorry that I missed the beginning, but I guess it would be my job as director of the Center for Health Literacy to ask this, but is there any way or thoughts to including health literacy measures? I know ARC has some in terms of perceptions of relationship and communication and understanding, but then there's also other measures that actually score somebody's health literacy, and I don't know if I missed that in the beginning or... I'm sorry.
What's the tool? Is there a tool? Like
CCAT, is that...
CCAT?
Did I miss that?
No.
Did you already go through that? Oh, okay.
You are good timing, and I can't read
sorry.
a dang thing on that.
Yeah, I wasn't able to read this.
Perfect segue, Linda.
I couldn't see what was on here. Okay, sorry.
It's awful. It's on there in terms of seeing.
Here, I've got it here.
Yeah, that's what I'm going to try and do. Okay, let's see if this works. No. I can't read it. Okay.
Oh, well, here, it's right here.
This was sent to us, and we could put it up larger.
Right. Okay. But for purposes of this meeting, and thank you, Lenny, for she was prompting me along the way to get this out there, and so we did get it all done under the wire. Yeah.
So let me just say that
Yes.
the larger version of this, I believe, is on the HSCRC site, and you can, didn't Greg post it? But not on a larger version. I think the full slide.
It's in PDF. If it's in PowerPoint, it could be more easily zoomed in.
No, on Basecamp, it's just the meeting packet, but I
It's
think
the PowerPoint version.
well, the PDF version on Basecamp.
Oh.
But the PowerPoint version should be on the HSCRC website. I'll look at it now.
It's like
Do you want to go to our website and the internet, and then we'll see if we can pull it up in PowerPoint and zoom in. That would be great, Kim. Okay. Just can we escape out of this? Or no, you have brains. Okay. Okay. The first measure, anyway, as Kim's working on that, is
Can you just explain that these were proposed.
yeah.
Thanks.
So we had a performance measurement work group meeting on the 22nd of June, and the goal of this meeting was to think about what are the future strategy and components of a strategy that we need to think about to get to a more person-centered, consumer-engaged, population-based performance measurement approach and overall view of the world. So what we engaged through Alice Burton, the CERN Health, and Tom Valek in particular, was to look at the universe of measures out there and to help us understand which of these measures, and he went to those sources that I described already. He went to ARC, he went to NQF, and pretty much I think he was wanting to make sure that there were some NQF endorsed measures for the domain areas at which we would be interested. Yeah.
Would you rather read it up?
Yeah, it's great. Beautiful. Are you able to get to the internet?
Okay, it's like page 60 or something of the long.
It's not showing on the webinar, though. So let me just walk through this, and then we'll make sure people get a copy of it. So, okay. So the first one is cultural competency implementation measure. And this is a shared decision-making measure, and this is also a meaningful use measure that they expect will be submitted electronically. And that it's an organizational survey designed to assist healthcare organizations in identifying the degree to which they are providing culturally competent care and addressing the needs of diverse populations, as well as adherence to 12 of the 45 NQF endorsed competency practices prioritized in the survey. So this is somewhat process or structure, if you will, in terms of being a survey measure, and adherence to best practices. So the expectation is that 80% of all unique patients have demographics recorded, including the language, gender, race, ethnicity, et cetera. And then the designated care setting for use of this measure is ambulatory care, a clinician's office, urgent care, emergency services, ambulance, home health, hospice, hospital acute. In other words, you can use it anywhere. And then the level of analysis is the facility. It could be analyzed at a plan level. It could be looked at from an integrated delivery system standpoint. And so if we think about all the, 700,000 plus fee-for-service patients in Medicare in the state, and think about them virtually somehow in terms of an integrated delivery system, you could, if there was a way to use this measure, you could use it for the Medicare population or all payer. Just you'd have to figure out a way how to survey all these providers.
Does the et cetera, do you know what's in the et cetera? In other words, does it include gender identity and sexual orientation?
That is a really good question. So I would go back to the measure source and ask, and I had trouble, especially with the CCAP measures. I couldn't get to the core document. Were you able to find it?
I just didn't have time to go beyond the framework.
Right. So I contacted and these are the other measures on this list. I contacted the person at the university that they had on the website, and I'm waiting for a call back from her because it says you can download the CCAP survey and use it for free for research purposes. But there was no clickable download to get the survey anywhere.
And do people know what the CCAT is?
And I'll.
The university.
Yeah. Yeah, of course, Linda, you would ask that question.
No,
I'm sorry.
I knew that could help.
Yeah, you may. So it just escapes me which university. Okay. The second measure that was not necessarily on a list that, Lenny, that you had intended, but I thought I wanted to put it on this list. And this is the hospice and palliative care treatment preferences. And these are patients with chart documentation of preferences for life-sustaining treatment. And this is also a shared decision-making domain measure, end-of-life care. And it says it's part of a cluster. And it can be collected in the EHR for stage 2. And I believe that refers to a, that's Tom's stage of our journey. So that comes before stage 3, that I know. I think we're in stage 1 right now. This is stage 2. And it can be at the group or facility level, and it could be at a hospice or acute care. It is a facility-based measure. And it may be similar to our medical order for life-sustaining treatment requirement that's already in place in the state of Maryland. I don't know how closely it's aligned because the measure specifications may be a little bit off, but we do have an analogous measure here in the state. It's not for every hospitalized person. It's for someone who enters a non-acute facility, every person who enters a non-acute facility, or if they're readmitted to a hospital. Is that right? Does anyone confirm that about MOLST? The most? I believe that's true. Yeah. Okay. So then, now we're getting into the CCAT, which is the Communication Climate Assessment Toolkit, and that was developed by the American Medical Association. And I see that Lenny made a copy of the 9 domains of communication that it evaluates. And these, should I just read them off? Do you think?
Sure, and those were also up in the materials that Tiffany
Great.
put up.
Perfect. So their leadership commitment, information collection, community engagement, workforce development, individual engagement, sociocultural context, language services, health literacy, and performance evaluation. Linda, do you want to say a piece about it?
No.
Can you put the mic on?
Well, my answer was no, but now that the mic is on. No, I just wanted to make sure that we had something going forward, since health literacy, I think, is a key part. And I don't know if we want a discussion between perceptions versus a level, because so perceptions get at, how they're perceiving the relationship with the hospital, the physician, how they perceive the communication, and maybe trust. It's very important. But I don't know if we have the space or the time to think about measuring their health literacy, because because knowing people's health literacy may then assist the hospitals and the physicians moving forward. But if we take a universal precautions approach, which is we assume everybody has low health literacy, then maybe it's not as important to measure their actual levels. Just communicate to those players that they should just assume a low health literacy and communicate as such.
But so if you are assuming a low health literacy level, and then your goal my goal would be to improve health literacy, how do you know that you have improved?
Yeah, you can't. That's actually. Thank you. This is sort of ongoing debate. I call it different paradigms that play together in the health literacy field. The one paradigm is, and this is what ARC takes on frequently, this idea of the universal precautions approach, meaning assume everyone has low health literacy, because then you create communication that works for everyone. Does that mean?
No.
Okay. So you're not measuring health literacy then, and your goal is not to increase health literacy. Your goal is to move beyond what might be a barrier of low health literacy and get to adherence, medication management, and these other goals you have by working through the low health literacy by being effective cultural communicators.
I see.
So that's one paradigm. The other paradigm, which we all also adhere to, is this tailored messaging approach, where you want to try to improve health literacy, so you tailor your messages and communication according to somebody's health literacy level. So your messages may be different for somebody like Gary, who, like you said, is the smartest person in the room, versus someone like me, who has very low health literacy when it comes to hospitals. So you tailor the messaging, and then you try to improve my health literacy and get my level to a higher level to then move forward with my own medication management. I see them as neither wrong or right. I find them to be sort of dueling paradigms in the health literacy world. And I think we need some of both. But measures tend to do one or the other. See what I'm saying?
Yeah, well, you can measure literacy and you can measure outcomes.
Perceptions, right. You measure perceptions to help the physicians communicate better. You measure a score to see how you could raise that score. It's just a matter of how you want to move forward.
Right. Well, so this tool in particular is done at the provider level, and you can go across the care continuum provider site, and so there's three that were extracted that Tom pulled out from the CCAT tool. So one is related, measure of health literacy related to patient-centered communication derived from items on the staff and patient surveys of the Communication Climate Assessment Toolkit. And then the second one, so that's health literacy measures derived, and then the second one is individual engagement measures derived from the same tool. And then the third is language services measures derived from that same tool. So there's a lot of questions. Does that mean 100 questions, 0 to 100? Or is that a score? A score. So there's a score. You can score 0 to 100. So they have a range of scores. So.
Can I suggest, just mindful of the rest of the agenda, that that one of the reasons to raise this is within the construct of the communications strategy document that we're working on. We need to, this measures piece is a chunk that is missing, or it's not filled out. So I think we wanted to be sure to put these on the table to think about as we're going through the document, and then to get feedback from everybody. And I know, Linda, that you were going to be thinking about this, and in particular about these health literacy ones, and do these do what we want them to do? So maybe we can get any immediate thoughts or questions about this and then move on to looking at the document. Does that work for everybody?
It does seem like the approach of using universal precautions, kind of an approach when we are producing documents and putting them out, is something that would be very useful. And it feels like we would be remiss if we didn't also have some measurement of were we being effective. So I think that both approaches have a use, perhaps in different areas of what we are working on. Because it would be a crime if, 4 years hence, nobody knew any more about their options than they know now. In the meantime, you want to target everything at a level that people can understand it. It may not be to the 6th grade level, but if we can get to the 8th rather than, something else, that's a good thing to do.
Any other thoughts? The other thing I hope everybody will think about is back to the cultural competency one, or as we like to think of it, multicultural engagement. I just want to keep pushing that idea as a different way of looking at it. But does that, just looking at it at the organizational level, does that get us to where we want to go on this, or is there some way we could push a little harder or measure in some way? Because I think I was just talking to Alma Roberts about how I know at some of the MCHI forums, the question about how's the new all-payer model actually going to address health disparities. So this is part of that equation, is how are we going to move the needle on that as we're doing the rest of this. Did you have something to say, Kim? Did it?
Can you?
Well, let's just.
Hello? Just happened. I just lost my,
Yeah, it's probably, switching cell towers and what's going on here.
You can edit everyone. This is what crazy myself was. I just want to go, okay.
you're connected using this, using the internet, but I'm not hearing it.
I started talking to him. That's it. It's enough. He told the story. Move on. I'm not at it. So.
But he didn't do that. The team makes it work. You have left to merge up to my 91 to a partner.
We're talking. Get very excited. Me, when something about myself. I'm so kind of like, I can't stand it. But the radio show, I can tell you, most people have tremendous purpose drive, and they really don't have that much to say.
That's weird.
in terms of content. The drive is there, but the content is not. That's right. That's blah, 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 blah. Got it, sure. And find people who are just not on the side of this. But how do you feel? Well, it's right to the subject.
36 miles. Continue on I-91 North.
What the heck happened?
Plus, I'm an expert. Not everything. Not everything, but I'm talking. That's right. They get your path. They're supposed to be. So they have to, people are making charges as they're heckling. They get your path during services. Sunday, any of the Sunday morning service at Lakewood Church in Houston, shows 6 people standing and shouting at full speed while free service went on. There's churches church. They were church and taxes about Houston. They say they've been charged criminal trespass. I don't know what is another church. That's cool. Church is protecting another church.
How do you measure health literacy?
There's lots for it. It's just that it's cumbersome. There's nothing that quick. There is one that's allegedly 3 minutes long with 6 questions, but I think it takes longer than that in my own pilot testing. There's nothing self-administered quick for it of a health literacy level.
Well, and keeping in mind, these are all surveys to a provider group. They're not to the patient at all.
So when you, to a provider group, but they're measuring.
Can you turn?
Oh, we got one.
Are we on?
We are, and let me just say that Hillary, who's going to be going, who's now back on, I hope, good, has to leave us at 11:30. So I just want to, maybe we can get to that, to Linda's question and Diane's response, and then move on. And maybe you need to repeat your question, Linda, because.
No, it's fine. I don't. I'll bring it back around later.
May I just add to this discussion that I'm not familiar with the tool that you're referencing, but, there's this issue of checking or gauging a patient's health literacy, but then there's also the piece that requires the person who's delivering the education to have the skill set and experience to be able to alter the level of information that they're delivering. And so I was trained to just make sure that everything is at the same reading level versus trying to assess someone's health literacy level and then adjusting my message based on my understanding of their understanding. Is that what you were?
That's what I was saying.
That's what you were saying.
I was saying there's two paradigms.
Right.
One is the way that.
And so you agree with the.
I was saying a universal caution approach is the arc metric.
Right.
And so if we're going with arc metrics, that's why it works, because that's their paradigm. If this group wants to measure health literacy because it's about patient engagement.
Right.
So, patient engagement is not easy. It's been frankly done as if it's easy, and that's why I don't think it's been successful. So if this group wants to be challenged and really look at how to increase patient engagement, that might be looking at health literacy level and how to increase it. But I think it's not easy.
Right. I just wanted to make sure that was what I was hearing you say, because I agree with you
Yeah.
that we should just stick with the universal precautions.
Yeah, I would say the first is very important to us in the generation of materials that go out. The second may be more important in terms of actually achieving a cost reduction if we were to look at a particular population. If we have high-use populations with low health literacy, changing their ability to understand the system and therefore engage with it may be one of the more important things that we can do in terms of achieving a more efficient utilization of the system. So I think they each have their places. The first, I can't see how we do without, because we have to assume in everything that we put out that we're talking to the broad population. The second may be much more targeted in terms of its application because it's higher resource use. But it may also be that it is important enough that we want to include it at some point. It is less important as we generate material to educate. It may be more important as we measure achievement of our engagement later.
It's almost like you're suggesting a phased approach. Sorry, it's like you're suggesting maybe a phased approach. We do a phase 1 universal precautions approach, phase 2 targeted, tailored to special needs approach or something. And maybe we strategize around the second while we're implementing the first. Give us time that we need to address the challenges.
But to further complicate things, there's health literacy that's kind of basic. It's a part of a person's makeup there. For whatever reason, they have low health literacy, but then there's also kind of situational health literacy, where if someone has just received a really significant or serious diagnosis, then they're not understanding what you're saying. If they're not feeling well that day, they're not understanding what you're saying. If their medical condition causes them to have blurry vision, all of those things are still considered factored into the health literacy level. So it just seems the phased approach from a researcher / scientist perspective sounds like a really good way, but there's no way for us to control for all these other variables that influence someone's ability to understand the health information and act on it.
This is Hillary. It may be a matter of thinking about a phased approach not in terms of the timing through which you phase it, but phasing by target audience. And so I'll get into this a little bit later, but if you look at the pyramid of audiences, there is the general public at the base of the pyramid, and for them, the sort of all precautions approach where you sort of assume that there is low health literacy throughout makes sense. But then as we move to the more targeted interventions and the more targeted ways of engaging with people, then we're actually looking at changing the behavior, moving the needle on health literacy. So it's phased by audience rather than by timing.
Thank you, Hillary. So let's move into a discussion of the now getting to be very meaty document. And I was thinking about the process that we've gone through to get to this point, and it reminds me of creating a great work of art because it's really messy. But the end product, clearly we're honing in on something that will be worth putting on a wall, or at least being used by the powers that be. So. I do want to thank the members of the subgroup that have been working on this, and Diane and Teresa and Tiffany, and particularly Hillary, because we definitely wouldn't be here if it weren't for you, Hillary. So I'm going to turn it over to you, and if you could speak up a little bit, because we're in this vast echoing hall here, so that would be helpful.
Sure, I will try to be as loud as I can. And I also want to start with an apology. I'm sorry that I cannot be in the room with
Hang on just 1 second, Hillary, while we work on some technical things here, like trying to turn up the volume on the phone.
Okay. Well, as you're working on the technical, I'll also give my disclaimer, which is that I arrived in the office this morning to find that we had no internet. So I turned around and came back home to join the webinar, but I am without the benefit of my slide deck with the notes. So forgive me because I'm winging it a little bit.
Oh, well, I'm sure you can manage that.
So if we could go back 2 slides. Ahead 1, because this first one was for the disclaimer. And so, as Lenny said, we've been a long time working to get to this point. And so in sharing where we are, I thought it made sense to look back at our initial charge for this part of the task force's work. And that was to provide a rationale for health literacy and consumer engagement defining audiences, messages, and the reason for education and communication strategies that are appropriate within that consumer engagement, and reflecting the outcomes from the communications and community outreach task force and the focus groups and the forums that have been going on, as well as the care coordination work group and their recommendations. Next slide. So as with any type of strategy, you want to start by defining goals. And the goals that we have are directly derived from the principles that we discussed in the first couple of meetings of this consumer engagement work group. And one of the ongoing threads in the discussion that the subgroup has had over the last several weeks is tracks directly back to measurement. And do we need to measure these goals? How accountable do we need to be to these goals? And where we landed is that no, the goals can be lofty and visionary and really extend beyond, certainly beyond the next 18 months when the sort of first big deadline is, and beyond the next, the 5-year point as well. So these are long-term goals and speak to a level of behavior change that we're looking for in the target audiences. And we know from looking at other campaigns, for example, smoking cessation campaigns that are pretty well known and understood at this point, that behavior change takes time. You're looking at 20 or 30 years before you see the full results. So the goals give us an end point and a direction, but in actually implementing the work, we have to step it back a little bit. And one example of really how visionary we want to be is this latest goal that Lenny added last week, which is transforming the health delivery system to support consumer engagement. And that sort of tracks back to a quote from Don Berwick that I think he said in a film that said, you know, stop trying to make the broken system work, instead fix the system. So those are going to take a really long time. Next slide.
Can I just ask, Hillary, I'm sorry, how do people feel about that third bullet? I was concerned that in the goals, everything was put on the consumer, but we're really dealing with a system that needs to be fixed, so, or addressed in ways that enhance and support what the consumer piece of it is.
Well, this third goal is kind of consistent with what I had raised, which is I wanted them to see something more outcome-oriented. Like, we want them to do all this stuff, but why do we want them to do it? What does it look like once they've done it? And so I think that this kind of gets there. But I also think it should be something related to health, because we want people to be healthy. We want them to be engaged and educated and activated because we want their health outcomes to be optimal. And I'm not sure that we've gotten there yet in terms of goals, but I think that kind of gets at that.
So we'll take that to the subgroup. Yeah.
Okay.
Sorry.
Next slide. Oh, and so this may actually track to some of what we were just discussing. So what does success for this work look like? And here we're really thinking about it in terms of the consumer and their health. And as you'll see, the 3 sub-bullets, they really track into the triple aim. So we want target audiences to understand the health system and how it should be used to achieve and maintain good health for them. And then these 3 sub-bullets translate that triple aim, which we're so used to thinking of in terms of the healthcare system, to the consumer. So the positive experience, that's the same on both sides. Good outcomes. Now, it may be that good outcomes from a consumer or patient perspective are a little bit different to good outcomes from a system perspective, because you're looking at from the macro and the micro lens. And then lower costs to the system, which in turn should translate to lower costs to the patient, again, over time. And of course, you know, we're doing this in the purposes of the new all-payer model. So we want to have improved health and cost reduction in the Maryland healthcare system. Next slide. So bringing it down to something that's more grounded and a little closer to reality, we need to look at objectives. And the objectives and measures, of course, should work in conjunction.
We lost you, Hillary.
Areas need to work in conjunction with each other.
Hillary, can you?
And
I think you're back, but we lost the first part of what you were saying for this slide. Are you on a cell phone?
I'm not. I can dial in. I'm using my computer mic.
No, you're fine now. We just lost you for a little while in an echo chamber. So can you just start fresh on this slide? That'd be great.
Sure. So going to the top, the idea is that the objectives move us down into something more concrete, while the goals and definition of success can be pretty visionary and set the long-term view. The objectives need to be more grounded and need to track to measures. And this is an area that needs more work, as we've noted, because the measures are still coming together. So this is certainly preliminary, but objectives would be to provide the information that people need to become healthcare aware consumers who are engaged in their own care, empower people to contribute and participate in the discussion about the health decisions that are going to affect them. And how do we do that empowerment? We give people the information that they need in a manner that is clear, that's, culturally sensitive, that is cognizant of their literacy level and the language that they speak, and that they can take action on. And we need to educate people about the most appropriate places for them to receive the different types of care. And just anecdotally, I was working on some focus groups back in May, and something that really struck me in those focus groups was that consumers don't really make a distinction between insurance companies, primary care providers, hospitals, imaging facilities, diagnostic facilities. It's all healthcare. So within the system, we have these categories and areas and silos, but from a client perspective, from that consumer perspective, they're not making a distinction. These are the people who I go to get my healthcare, and they should be organized and have it together. So, so that point about helping people to understand the distinctions between these various settings, I think, is quite important based on what we learned in some of those focus groups. Next slide. Also in the objectives, making sure that consumers can engage meaningfully in their healthcare with some of the things that we've heard about from the care coordination work group, things like care planning, giving people self-management tools, and providing them with additional services and assistance if needed. And of course, creating connections between the government and hospitals and healthcare providers and the individuals. So this is going to that question of transforming the system. If we want the system overall to be more consumer-friendly, it's important to have that consumer voice present when the policy decisions that are being made to design the system are taking place.
So, Hillary, can we just pause there for a moment and get reaction from others if there is something? My own question is whether the create connections, is strong enough and gets to what we're talking about, just to your last point of the transforming the system. And Linda has a comment.
Do we, as a group, want these objectives to be specifically measurable so that for a couple reasons. One, when we do pick the measures, there is a direct connection between each measure and an objective. and also then we have specific ways to say whether we're successful. So I think these objectives, like Hillary said, they're work in progress. I think this is amazing work, Hillary. But I wonder if, for example, empower people to contribute might be difficult to measure as an objective. So we have these great goals, but is it something like, increase, and we're doing measures. So if we say something like increase awareness of the different players, if that's something we want, by 20% in a year, then we might have measures to look at that. Or increase knowledge of how, the health insurance plays out by 30% or something like that. And maybe that's too specific, but maybe a little more specific in the objectives to measure them.
We had some discussion at some of the subgroup meetings about the ability to apply the SMART principles to these objectives, and it would be very difficult and labor and resource intensive, but I do think that we should start looking, and maybe we can take offer from what Lenny said, which is looking at ways that we can transform the health system, elements of the health system that we can transform to be conducive to this communication strategy, so then we'd be able to measure that. If we can influence policies or procedures or practices in the institutions versus trying to figure out first how to disseminate these messages and then find the resources to be able to measure whether or not we've actually achieved these things. So I think, that's our challenge here, is like trying to figure out the balance between what's too specific, but how do we find something meaningful to measure?
And I remember having that SMART conversation before, but you could take the M and not the SART. I mean, it could be, it could be a compromise. But I think it goes back to our goals.
So here, the answer to your question, I think that you can make a linkage between some of the measures that are out there with and potentially still use some of the words that are a little more lofty, if you will. Mm-hmm. So it's like people having a care plan or a care manager. Those are create connections, you know what I'm saying? So I do believe that some of the measures you can make a very strong case would, and I actually like these words. So then you put the actual what you want to get in the measure itself. Like you want to increase this by this much over this much time. Whereas these are overarching messages that are more that seem more powerful than just saying increase by 20%.
I remember I wanted to say one more thing. I'm sorry, I forgot. I'm getting old and I can't remember half my thoughts anymore. When I make communication plans, we actually do often have a set of process objectives, output objectives, and outcome objectives. And so this might get back at what Tiffany said. So the process objectives could be measurable in terms of how many materials and how much work, what we're doing as a group, or what whoever's doing it as a group, what the system is doing maybe. Then the output objectives could be how many things are distributed, and the outcome objectives might be the actual things we want to see 5 years hence or something. That's another way we kind of deal with this challenge of how do you actually measure behavior change, for example. It's always a tricky thing. We always look at awareness and other proxies for that, intent, stuff like that. But maybe we could have a smaller set of communication process objectives and then the objectives we want in the actual audiences.
And Linda, I'm happy to work with you on
well, let me suggest too that we're not being paid, in quotes, to create, and I think Hillary's probably back home saying the same thing. We're not being paid to create a full-blown communications plan, right? So, but we want to lay the framework upon which that is the next step, is filling these out. So identifying the need for those objectives and providing some examples of specific measures without feeling that we have to provide every one, and potentially also, I think, to comment on the ones that are being considered now, such as the health literacy and the multicultural engagement / cultural competency. Hillary, do you want to weigh in on that? Because I just quoted you.
Right. No, I mean, I think I very much appreciate your point about we're not doing the the implementation, we're not creating the plan for rolling this out completely, and there will be some refinement that needs to happen. However, I do think that there may be benefits to doing the grouping. I thought that the comments about creating the buckets for process, output, and outcome could be very helpful. And then also, I really liked Diane's point about defining the measure within the measure, and then letting the objective be an umbrella statement that may have 2 or 3 measures beneath it that are very specific and show the exact movement that you want to see.
Great. Any other thoughts, or should we let Hillary move on? So, because you probably have to leave earlier than 11:30 now, because you got to go back to the office.
Yeah.
Oh wait, hang on. Kim's got a comment.
I was just going to respond to your earlier comment about the 5th item and the create connections. I actually like create connections or establish connections, because this is talking about the system of government and hospitals and healthcare, and so putting linkages in, like having an HSCRC director who has the charge of ensuring that the patient has, or the consumer has an ongoing voice, I think is the kind of thing that we're talking about there. So I like that approach. Create or establish or implement or suggest. Those are things that kind of relate to where we are in the structure itself.
Good. Thank you. Kim?
I don't know if this is really appropriate, but I was thinking that maybe what's missing in number 5 are the community organization partners. But I don't know if you want to reach down to that level. But for some folks, I was thinking that they may be less intimidated. They might be more engaged with whatever organization is right at their local level that might be tied in as a partner.
Yeah, that's really important. Thank you. Hillary, you want to forge ahead?
Sure. Next slide, please.
Sorry, I got distracted.
Okay. And so I think we've covered quite a lot of this in the previous discussion, just sort of talking about the fact that we still need to do more work on the measures, and to reiterate Diane's point in her earlier presentation, want to make sure that the measures are reliable, valid, and relevant. And, there's a lot of measures out there. Let's not make life harder than it needs to be by creating something new. Rather, to the extent that it's available, tap into what already exists. Next slide.
Thank you. And I would note that Michelle LaRue and Susan Markley are on the line, right? Good. Okay, Hillary.
So to segue from the measures discussion into audiences and messages, I just want to make the statement that while I did say we should tap into what already exists, we should also be cognizant that a lot of what exists is more relevant to the system than it is to the consumer. And so as I look at some of the measures that, at least those that I'm aware of, what I see is measures that are really more patient engagement measures than consumer engagement measures. And I think that there is utility in using those in tracking some of this, but that we should also be aware that consumer is sort of a broader definition, and that we should keep that in mind as we're looking at all the measures. But on to audiences and messages. Back one slide, please. So this trajectory, I think people have seen in other contexts before, but I find it really useful and foundational in thinking about behavior change, where you have to move people in their awareness of any subject, and you have to move them to action. And so people start with zero awareness. New all-payer model, what is that? I've never heard of it, and I seldom go to the hospital, so it's not really relevant to me, and hospitals get their money, and if I go in, I hope I get healthcare, but I'm not worried about what's behind the scenes. Zero knowledge. you have to take folks by the hand and kind of move them along the stepping stone path to that point of awareness when they're beginning to say, okay, I understand this, it's a little esoteric, but I can see how it's important and that it might be relevant to me. And then keep taking them along to the point that they're saying, okay, I really get this. I see what it's about, and I see how I can play a part in making this work. I see how my actions will make a difference here. And that's when you get to that very top level of the action or behavior change. Next slide. So I thought about that movement in terms of the audiences that we had identified for this campaign. And as you see at the base of the pyramid, we've got the healthcare pyramid that we're often used to seeing. And at the base of the pyramid is the general public, because per our definition of consumers at the very beginning, we have people who are users or potential users of hospital services. So that's pretty much everyone. Of course, you can reach a broad group of people with that preliminary thing. Just, hey, let folks know that this new model exists and that it's interesting. Maryland's doing something different. As we move through the audiences, the messages that we deliver to them are going to need to get more specific and tailored toward that behavior change. But it's really important to emphasize that the people at the top of the pyramid fall within the general public as well. So if you see messages for the folks at the top of the pyramid and there's only 3 messages and you're saying, well, why do the people in the general public get a lot more information? It's not that the folks at the top of the pyramid don't also get that information. It's that they get that plus. So I just want to make sure that that's really clear, because it's been a question that's come up frequently as the subgroup's been working through the document. Next slide. So thinking about the general public, the messages that we're looking at for these folks are really, as I said, it's awareness raising. It's letting people know that something interesting is happening and that they're part of it. And then it's giving some general tools about, ways to approach how you think about how you're going to access healthcare. That in Maryland you can shop for quality, because and procedure costs shouldn't influence your choice of hospital. That the new all-payer model will help you get the right care in the right place at the right time, and here's how. These various things about the model that are appealing to consumers, as we've learned through the focus groups and forums that have already taken place. Next slide.
Hillary, let me ask you. I have a little discomfort with cost should not matter. I wrestle with this.
So it's not that cost should not matter, it's that cost should not influence your choice of hospital.
And why is that?
So if the costs are set by the state agency, so it's sort of the comparison to the national system, which is the anchor point that people have, because there's been a lot of media attention to kind of the Wild West of what it might cost.
Mm-hmm.
And so, what we have in Maryland is significantly different to that.
Right.
Most people, sorry, go ahead.
Yes, I'm sorry, I shouldn't interrupt. So we have our hospitals under these global budgets. These rates are set by the commission, and still there are inefficiencies in when you look at across hospitals. There's inefficiencies from hospital to hospital. Some hospitals do better in terms of providing efficient care. Now, granted, where we want to get at is the total cost of care for an individual in a year, or per capita cost per year, is in the aggregate, is where we want the whole system to come down. So I get that as a mid-range goal, But what I do see is the only way we're going to get there is if each hospital that's inefficient does their part to become more efficient. So the rub for me is how and why consumers should or should not care in that intermediate intervening time span. And it may not be that we need to spend a lot of time on it. I just want to make the point, and we can stew over it a little if you want, and then we'll...
Yeah, I would, with respect to that, I would say that there will be people other than us who pay a lot of attention to the hospital-to-hospital comparison and create systems and incentives to change that number, or amongst hospitals. So I'm not sure we have to spend a lot of emphasis on it. Having an awareness that it would be a socially good thing to do to use the most efficient hospital might be kind of as far as you go with the consumer side.
So let's table that and continue the discussion and let Hillary move on so she doesn't leave us in the middle of this.
Right, but point made, and
Yep. Start.
Okay. So on the next slide, what you'll see is that, as I said before, we're building on the messages that people have already received. So we're moving them from that point where we've given some general awareness, and so they'll receive all the same messages as the general public, and then some of these other messages. And these are for people who have used hospital services, but who are not frequent users of the hospital services. And this is a place where we can really make the biggest difference, because once you get to folks who are in the high utilizer category, you're talking about people who are very, very ill. And there tends to be reversion to the mean. The same people don't stay within the point of the pyramid for very long. They either get better, which is the preferred outcome, or they do not stay with us in this realm, which is the more unfortunate outcome. But what we want to do is prevent people from moving from this middle block of the pyramid into the top block of the pyramid. And so here we want to arm them with some of those tools to make sure that they can take action and so making sure that they know how to manage their care, and that they're connected to primary care providers, that they know who they can call if they need help, and that they have confidence in the services that they're receiving. Any questions on that one?
Nope.
Next slide. And so here we have the pyramid, and we want them to say messages as the generic.
Hillary, you're cutting in and out again, so I wonder if it's, I don't know where your phone is placed or how far you are away from it. Oh, you're voiceover. Oh, it's a voiceover. Okay. We'll pick it up again and let you.
Might help. So with these, and I think something that I want to point out is that the line between these blocks, solid line, there may be some fuzziness here, and so we might want to share some of this with the people in the middle block of the pyramid as well. But certainly for those at the top, making sure that the individuals themselves and their caregivers are armed with the resources that they need to take care of themselves and their family members. So having that care plan, making sure they understand the care plan, and making sure that they know who to ask if they need help. Any questions?
So I would just point out for everybody, Hillary, that that on the, I'm going to call it the master document, there is also a section on engaging the messengers, which was part of our charge to look at that. So we can look at that as a group later. Does that make sense? Sure.
And I'm afraid I don't recall if I had that as a section on here. I may not have.
Yeah, it's not on the slide deck, which is fine because we can come back to that.
And I believe that this is an area, too, that we've spent quite a bit of time on because, in a sense, we actually started with the messengers. We had that big matrix that we looked at for several weeks and trying to build it out. So I'm hoping folks are more familiar with that. So the final piece is looking at the strategies and tactics. And so rather than reading through them all, I'll give folks, 1 minute to glance over them. Is that okay with everyone?
That's fine, thanks.
Okay.
And then also just understanding that in the master document, each of those is broken down, and that's what you're going to discuss, I presume.
Hi. So has everyone had a chance to look over the strategies and tactics?
Yeah, go right ahead, Hillary. Thank you.
Okay. So what I wanted to just point out about this is that I think it is very important in the context of what we were discussing earlier today, because you'll see that in these areas that there are those tactics that are direct to the consumer, with things like looking at making sure the materials we produce are language appropriate, culturally and linguistically sensitive, accessible, are developed with consumers as part of that, of the process of creating them and so on. And so that's engaging directly with the consumers and making sure that the materials we create for them and the information we push out to them keeps them in mind at all times. And then you'll see others that are more about changes in the system and the way that the system interacts with the consumers to be more inviting and warmer, in a sense, to the system. So it's and that could involve things like, well, what are the policies about how consumers can submit concerns or praise of the care that they've received? What kinds of programs do we have in place to really help consumers be more engaged for those who need it? Can they get the medication therapy management? Can they get an active person to help with their care planning and care management and so on? So you'll see that these strategies and tactics take both that top-down and bottom-up approach. And to the next slide, so let's go back and ask if there are any questions about those areas. And sorry, I will just note as we're going back that within each of those 7 sort of main areas, there are actions and specific steps defined. So if you go to the document that was circulated, you'll be able to see what those are in more detail. Okay. And then in closing out, we've had quite a lot of discussion about how to target this and how to roll it out. There are a number of approaches that we could take, and in the discussion in the subgroup, it seems to make sense to take a multifaceted approach that would involve using the Sing Index of neighborhood, it's called the Sing Neighborhood Deprivation Index, which is kind of an unfortunate type. So I like Sing Index more than neighborhood deprivation. But essentially, it uses census tract data to identify areas that are going to be have most high risk for health concerns. So it's sort of linking into the social determinants of health. And so we would look at those to identify the census tracts throughout the state that might need a lot of targeted intervention. Then more broadly, collaborating with the regional partnerships and the groups that are working on transformation plans. And with that, would need to move very quickly because, of course, those plans are due, I think, at the end of this year. So trying to share these ideas with the folks who are creating plans for their regions to make sure that they are thinking about involving consumers and that voice. And
yeah, unfortunately we lost you. I think it's the weather is affecting the brain power of the IT. Try it again, Hillary.
Sure. So this is down on the third bullet, which is the very macro approach, and that's to take a phased sort of general engagement throughout the state, starting in the areas with the greatest numbers of high-cost and potentially high-cost patients. And in that, you'll see, if you look at the geographies, a lot of it will actually translate as well, because if you look at the geographies, you're looking at areas where there are media markets, and a media market really extends beyond just the sort of defined county or city area. So there's overlap. So I know that there's been some concern that there would be gaps, but if you really look at the media markets and the maps, I think a lot of it will convey. I think it's very important to say that we should not be leaving anybody out of this, of the rollout plan, but that it is also important to do the rollout in a strategic way where we begin to have the greatest impact early on where we can, and then keep working over time. Any questions on that?
Not a question, but I had a comment on the regional transformation grants, and perhaps a minimal thing we could do is provide them with the core principles that we have on consumer engagement as a tool, if that seems helpful.
Yeah, we had talked about that previously, and I wonder if there is a venue where the group would be together where Lenny could be on the, we had talked previously about Lenny speaking and addressing the group, talking about what we're up to and what kind of support we might be able to provide as they move forward with their project.
Well, we know the next two opportunities are the 9th and the 23rd. I think you're...
I'm still here.
You're leaving on the 24th.
Yeah, I may be otherwise occupied, but we can, if we want to see what their agendas are. I think that was the issue the last time, was
a little bit of time on the
and it was like the next day or something. So yeah.
And that's
yeah, it's a good idea. So Steve Ports is here, and he's not here right now, but he's our primary staff liaison at HSCRC with the work of the partnership. So let me get back with him. So the goal of this is to have it be what's presented to the commission, or is this going to turn into what we want?
Well, we can talk about, so let's finish out this while we have Hillary, and I know we've got comments, and then we can talk about your design for the report and some initial thoughts on how this gets integrated into that. Right. Does that work for everybody? Mm-hmm. So, Linda, you want to kick it off?
Sure. These are more just sort of suggested, and a lot of them are organizational things. The one question I might have is specifically what we're thinking these strategies are addressing. Are these strategies for communication? Are they strategies for audience approach? Because in my thinking and experiences, for example, location targeting is a strategy. So I see this slide, for example, as one of the strategies that we would do to get this campaign off the ground. So I would just wonder what we mean by strategy per se.
Sure, and I think I can address that. So the idea, was that the strategies themselves would apply pretty broadly, and they have specific actions beneath them. And I was thinking of the location targeting as more a model for rollout. It could be grouped in under the strategies section. It's not that significant that it needs to be separate. So I think it's fine to just put it into the strategies.
Yeah, I think it's just more when we get to our final audience and they read it, making it clear sort of these pieces in the plan. And if we say these are strategies, I don't know if a rollout strategy is all that different than, for example, providing materials that appeal to diverse audiences, because that's sort of like a rollout. I don't know. It's just an organizational thing. And when I think of strategy, I think of more evidence-based, theory-based ways to communicate or ways to approach it. And I wonder if we might want to go back to some of these and look at what might be theory and evidence that we can suggest why these are the most important ways to go in case we have questions. So, you know, looking at social norms, looking at self-efficacy, looking at things we know are important for patient engagement and communication that we can incorporate in the strategies. Like why would sense of ownership be critical if we could just stick in, you know, how much it's been shown that incentives are necessary to create motivation behind hospitals. Those kinds of little pieces might be, we could add for each strategy. I'm happy to do that because that's sort of that's what we do is communication strategy. And,
yes.
And then the last thing I wanted to say was I do see a lot of overlap with some of these strategies, and this is a lot, and I see a lot of tactical overlap. And I wonder if we might want to do a little exercise in bringing these together to make it more efficient list so it doesn't look overwhelming and undoable, but it would look really doable.
Sure, and I think that's an area that I would make as my final comment, because I'm afraid I am going to have to drop off in a minute, which is to say that the longer document did go out with the meeting materials for today, and I believe it also went out as a Word document last week. And so this would be the last opportunity for people to provide feedback, and we'll incorporate that. And then we'll take another really, really focused stab at doing a review and reducing duplication. One of the things I'm afraid that does happen when you have edit by committee is sometimes a lot of things end up in different places. But I definitely appreciate your point about that there is some overlap.
So we don't want to talk about that now?
Well, let's just, while Hillary's still on the phone. So the timing, the immediate timing, right, just to put that in place, there's a subgroup conference call on the 10th. So it would be extremely useful if we got really substantive comments back on the laundry list, if I'll call it that, Linda, of the tactics, right? By, if possible, by this Friday, close of business this Friday, the 3rd.
I just want to clarify. So email you suggestions but not do them, or just email, like for example, email you the suggestion, create evidence-based strategies, or actually create the evidence-based strategies and send those to you?
I would say the latter would be quicker
but if you only get the former, we still have another cut. So the next meeting of the full task force is the 17th. This kind of rapid timing was based upon the fact that we thought the interim report was going to, get pushed up. So, so if we get comments in by the 3rd, you mean people take Friday off as a holiday? What a bizarre thought. A holiday for their holidays? So, okay, well, let's make it close of business on Monday, because then you can work all weekend instead of celebrating. But you get an extra day. And so that then on the 17th, while we may not get everything put in here, we'll have a new iteration of this document to look at. Does that seem doable?
Monday's the 7th.
6th. Monday the 6th. Okay. So, Hillary, you're dropping off here?
I am. If there's anything else I need to know, please let me know by email. Thanks all. I'm sorry I could not stay with you for the whole call.
Thank you for just totally amazing work, really. We would, still be back in the dark ages. So much appreciated. And we'll, if there's anything earth-shattering, we'll fill you in afterwards.
Okay. Have a good weekend, everyone.
Thank you.
We should consider.
I say because I think it's Friday.
Sure. I'm also, the meeting on the 10th is a conference call. I personally think it would be helpful to meet in person. I don't know if that's possible or not. But you can think about that and we can get back on that. Everybody to the meeting on the 10th. Sure. Thank you.
So Lenny and I can just summarize in an email what was discussed today so that we can provide guidance to people when they're going through the document and making additional comments. But if we have next Friday the opportunity, if folks want to talk through their comments, if you're not part of the subgroup but you still want to contribute to that discussion, you can do that by phone. Okay.
So we've got a little bit of time left. So do you want, Linda, you had some comments. You want to add some comments now, and anybody else before we?
Well, I just didn't know if, just to clarify, for example, kind of condensing some of these strategies and looking at the overlap, if that was something you wanted me to do or just recommend to the committee to do later.
I think it would be helpful if you could do that.
So that would be a whole,
and so we can.
No, that's fine. Unlike everybody else, I have no life, so I can actually work on Friday.
I have no life either, so join the crowd.
But I just didn't know, because then that would look like a wholly different document. So if you're getting comments about the individual strategies and tactics, those are going to become unnecessary if we then condense it and create a more efficient list. So do you want to?
So I think it would be helpful if you did condensation and provided that to Hillary and Tiffany and myself and Diane, and then we can take a look at that. And the problem is, I mean, if we get it out to everybody on Thursday, but we tell them they need their comments back on this new document by close of business Monday, that's asking a lot.
I'm not sure that we need your piece. I think your piece is really important. I don't think we need it by the 10th, because I think that there's some other things that we should consider adding. I think, the Healthcare for All focus groups that have been conducted, I think we can take some learnings from those focus groups. I think that the presentation that we had early in this process from Lynn, is that Lynn's name?
Lynn Quincy.
Right. I think that if we look at the totality of the information that we've received, I think we can use your behavioral health kind of stuff, the qualitative stuff that Lynn and Suzanne. I'd like for us to take a more comprehensive approach to developing strategies that are informed by all of these meetings.
I was talking about two different tasks. So one was I can share the evidence-based strategies that I think are important.
Mm-hmm.
That's like you're saying with the other pieces too.
Mm-hmm.
Two is if we end up with only 4 strategies because they overlap, those 4 strategies, then you take everybody's evidence-based stuff and you can layer on top. So the second piece is more organizational. The first piece is more evidence-based. So you're suggesting going ahead and sending me the evidence-based stuff and not doing the condensation yet. It's a separate thing.
I don't think so. I think that whatever preliminary evidence base you can provide will be helpful, but I do think that whatever we include in our report needs to be informed by all of the information that we've been gathering.
But I think that, so from my point of view, something like provide materials isn't a strategy.
Right.
I guess is my point.
Exactly. No, I agree with that.
And so I was hoping that if we re-looked at the strategies to be evidence-based, regardless of where the evidence comes from, obviously, that we might get robust strategies that would then have these low-hanging fruit tactics and maybe challenging tactics, but they would be more efficiently funneled through an evidence-based strategy. For example, do we want to look at social norms? Social norms is a real pull. People learn about their health, often from family members. They often choose doctors because of a friend. So if we use that as a strategy, then what do we do to communicate under the strategy of social norms? That's kind of how I was thinking of the framework. I don't know how other people think about that kind of.
I think that's helpful. Are you available on the 10th? Just to have a brief presentation. What do you think about? Because if you share those and then to provide some of the rationale behind it.
Sure. I don't know about a presentation.
But I mean, I just mean walking through it, not slides and PowerPoint and all that.
Perhaps with what will then be the next iteration of this, because the reality is that after, I'm sorry, I'm just thinking this out, but if the subgroup discusses this on the 10th with the additions, then you could take a look at it. I mean, well, actually, I should reframe that. Could you take a look at it prior to the full task force meeting again in person on the 17th? Because we still have a month before the preliminary goes to the HSCRC commissioners. So the construct of pulling this in together into those tighter strategies can be done potentially after the 17th. Does that make sense? Because to me, there's some things, there's some things missing. Like, where in here are we looking at the health disparities piece and moving the needle on that? I think that's missing. And there's just, you know, simple things like these, the Informed Patient Institute tip sheets, that they're just a tactic under this. The other thing that strikes me is that this is not prioritized, to go to your point again, I think, too, and by honing in on that, because clearly we're going to need in the final report to have some immediate action steps.
Right. And Hillary did mention that was the next step. Like when she in her location targeting, she was talking about prioritization too.
Yeah. So what if in our next meeting we won't try to finalize this, but instead talk about other elements that we feel need to be added and what our approach will be, because we have the luxury of a little bit more time. Maybe we shouldn't feel like we have to finalize this within the next 2 weeks. Instead, we should examine what needs to be added.
I agree. I mean, I think the main charge for the subgroup and anybody else who wants to join it for the 10th is, to, if possible, get thoughts in ahead of time, but to be able to discuss it on the 10th and continue to refine to make sure everything's in it.
Mm-hmm. That's a subgroup meeting.
So if you were available, that's 9 to 11. Oh, I'm sorry, no, that's the 17th. It's 9:30 to 11, a call, conference call. We'll leave it at the conference.
So the agenda for that is, are we still soliciting comments on the document, or are we asking people to review it carefully and see what's missing?
I think, I mean, there's some people who aren't here who are make good comments, so I think we would like to hear from them as well. Are we looking for edits, or are we looking for everybody to critically look at it and say, we really need to add this? I think they could take this document and add under the bullets if they feel there are additional things that are missing, so that the subgroup and whoever else can discuss that on the 10th.
I just want to be clear on what guidance we give people on the latest document.
So the purpose of today was to get comments on this, and we haven't really been through the small bullet points. So getting comments from people on, you know, what's missing here, what's inappropriate, maybe there are things that should be deleted, and from the full task force. That would be my suggestion. By close of business on the 6th.
So are we, so my confusion is how, and we kind of had email talk among us, is how
the communication strategy is how, or what is known as, the document known as, and how that relates to what we might consider the final report. So if you're not ready for that yet.
No, I was going to say, it's up there, but I don't know that anybody can read it.
So, right. So, and Lenny had really thoughtful comments that the printer wasn't working along with our phones this morning. So there were two IT people looking at it as I was walking by it. So I didn't get a chance to review, but I reviewed them on screen, and I thought that they were really good. So what I wanted to understand was, so what I did was I pulled the report outline basically from the care coordination report. And so there are a few things that are not fleshed out or mentioned in the communication strategy that I would see as important in the report, or if we're turning the communication strategy into the report, we need to add it into the communication strategy. So go ahead.
Yeah, well, I think that there are elements of it that go in different places in the report outline, as you have suggested.
Okay.
Right? And then the strategies and tactics fall under number 5. So I don't think we necessarily take a whole and put it into the report, but we pull. And then there are areas, obviously, where we're going to have to add things.
Okay. So that's really helpful. So then that said, what we can do is walk through, and then Lenny, apologies again. I don't have your really fast, good comment that you'll I'm sure add into the conversation. Yeah. So and with that said, we're going to have the executive summary, which is a 1 to 2 page piece. It's nice if it's 1 page. I think that really tells you a line about what we did, why we did it, and what the ultimate the sum up of the recommendations are in terms of the product of this work group. So it is the communications strategy piece, but it's probably a little bit more than that. Like what do you have to do in addition to the communication or beyond? So and then in terms of background, we want to talk about the all-payer model, and then how this links with consumer engagement and why that's important. Because I think some stuff that Linda had presented a meeting or two ago about just merely looking at the numbers of what is the, if you will, business case for health literacy, and how that that is that addresses issues of consumer engagement. That having strong statements about that and laying that out in a background section would be really important, because and that's the piece that I didn't see in the communication strategy, but it could be it belongs in the report and not in the communication.
Yeah, I mean, that isn't what that document was meant to be. The other link I think that's really important to put in the background piece is that this new all-payer model does not exist in a silo. That its success is integral with that of the exchange and effective outreach to enrollment and health literacy practices, the teachings that are going on there, as well as ACOs and all the other things that are going on. So because that then gets you to the farther on where you're talking about the existing infrastructure. How do you leverage those opportunities?
Yeah, really, really important. And then, so the next point is the case for consumer engagement, but it's turning now toward population prioritization, and it's talking about why you're focusing on particular populations. So it's kind of the pyramid pieces, if you will, that matches nicely into this section, and then how we as a group determine what that hierarchy of needs was figured out. How is it that we determine that hierarchy? And then here in this broad vision section, we put in the key elements of consumer engagement.
Can I just add too that I think we need a very strong statement about the impact of consumer engagement on the success of the new all-payer model. We need to make that very clear, that link. Yeah.
Okay. Then the next piece would be, and I'm sorry, after background, we called that broad vision, and then we first wanted to link it into the three-part aim, meeting the new all-payer model targets, and then having the case and the rationale for focus and how we determine the prioritization. And then the next section would be existing infrastructure and gaps, opportunities to improve consumer engagement. And then we get to implementation strategies. So there's where the pieces of the communication strategy fit. The question would be, would we want to sort of reframe them and have the communication strategy as a separate piece, or do we want to pull the communication strategy into that section of the report? Is the question.
Yeah, so, I mean, some of the questions under that are what are the respective roles for different public and private sector organizations, and identifying infrastructure financing options, and specifying legal and regulatory needs. So I think it may be that for the preliminary report, that some of those things will get sketched out and not be in this document per se, but we need, as we're developing this document, we need to be thinking about those. And in fact, on the budget end, Tiffany and Hillary are going to get some ballpark idea.
Right.
For the communication strategy.
Right.
But I wonder if we could summarize. I wonder if I could summarize the communication strategy in the report, and then also reference it as part of the appendices. Like the full report should be there.
Yeah.
Because it's shaping up to be quite long.
Yeah.
It's like 7 pages, the communication strategy at this point.
Okay. So that to me seems like a good approach.
The one other thing I have, and I'm a little worried that this isn't necessarily, we haven't really gotten to this in some ways, is that identifying areas of responsibility and hence accountability for all of this going forward. I think obviously from a consumer perspective that's important, but.
Okay, so when we get to recommendations, is that more global than the strategies and tactics that we've articulated in the communication strategy? I have a sense that it would be, but it may encompass those strategies that Linda's going to condense at the end of the day. But it may also be a more global set of recommendations. So it's some of it might be very concrete, and some of it might be a little lofty thinking for a longer-term redesign system. So, and I don't know all of what the it is in terms of the recommendations right now. So I just wanted to put that out there and ask the question.
And when I was reviewing this, I was thinking that we definitely need all of this in our report, and I think we've focused a lot of our attention on this communication strategy, and we need to get to the business of thinking about some of these other things, because our recommendations can't be the Appendix A. We need to start thinking about some of this other stuff, and so maybe our future meetings need to focus on that.
Okay. And one of the things that we had talked about, remember the second charge is that consumer communications feedback loop, and out of that conversation came the gold star, for hospitals who meet certain criteria, and one of them we talked about were websites that were actually consumer friendly, and Teresa did that great, with help, I'm sure, from Eileen, that great survey of the 46 hospitals for those 3 categories. So I think we don't, exactly, we don't want to lose that, Sorry.
Oh, no problem. And then, and I don't know whether you've incorporated everything that you added in, but the last piece would be we know that there's important resources that we'd want to make sure were reflected in the report. So an additional appendix would include names and URLs and maybe a little explanation of what these resources are in maybe a one-page appendix, maybe 2 pages.
I think some examples, we want to make sure we interweave examples of good work that's being done, such as what the University of Maryland did with Atlantic General on the health literacy, getting it into the school curriculum, which I think is terrific, and what's happening in Prince George's. So we don't want to lose all of those that, yeah. Hmm? Yeah. Mhm. 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 Yeah, or if
I think the presentations aren't necessarily, I mean, right, they're not a resource that a person could go to reading this, but they do deserve to be brought up in earlier portions of the report.
In the process,
at some point.
We talk about our methodology.
Yes, yes.
When we speak about the methodology, we can summarize some of the learnings from some of the presentations. So there's definitely a place for it, because otherwise it just looks like we just sat around and said, hey, we should do this, or we should do that. So we can show that there's a little bit of science behind all
Yeah, maybe number 4.
well, and I had made a note but didn't mention it. I mean, under the vision or wherever the research that's been done on health literacy and the work we did should serve as background. But you can also, when you lay out the report, you can pull out just in a box just a quote about a program or something, and just, you know, it's without having to put a lot of text in there with the URL. So,
well, then I do think that we would be focusing on how to flesh out this report in, I would hope, the near term, in the next couple of meetings as part of the agenda. And you know, the 3 of us managing the work of flow of this would probably be talking a lot between now and then to provide something more substantial so that we could move forward with getting the gaps filled in. But so if there are any thoughts too on sections of this, and similar to what Lenny did, what is missed and where things might fit. If you want to edit, redline, and send it to me, that way I can be the sort of keeper of this at this moment in time, and keep it moving.
great. Any other thoughts on that? Otherwise, we'll move on. Okay. So we were going to have task force and subgroup updates, and I think we took care of the charge 1 and 2 subgroups. So, Suzanne, do you want to talk about the latest on the forums?
Sure. Since our last meeting, we've had 3 forums, including one in Baltimore County, Montgomery County, and Anne Arundel County. And they all were very similar in size, with about 70 people, and had all the local hospitals presenting at them. One of my favorite ones was the Baltimore County Forum, was opened by the health officer there, who started right off the bat with a charge to everyone who was in the room that this wasn't a time to sit back and learn about these great programs going on. It was an important time to actively engage, and as you were hearing about these changes, consider and then share in the discussion section how you were going to be involved and how you were going to support this work. And that led to some really great discussion, and particularly Franklin Square Hospital really taking a very deep dive in what they are doing for to increase their consumer engagement, and some of the outreach that they've done with their Healthy Babies program, and how that has really changed some of their philosophy about how they're going about responding to the changes under health system transformation. So that was on June 3rd. After that, we had an evening forum at Montgomery County hosted by Holy Cross Hospital. But I should also mention that these forums were also hosted after the announcement of the Regional Transformation Grants. So that kind of changed some of the focus of the forums compared to the ones that we'd had before that announcement. It was exciting to hear about these new partnerships that were going forward, and it provided a very clear kind of vessel for continued engagement and clear goals of what all of these hospitals that were presenting on their individual things, what they were doing together to work and address some shared goals. So Nexus Montgomery was presented And that was also one of the largest turnouts of private citizens and faith community health nurses. It was also, there was a recent change to our evaluation form once we were hearing that a lot of people wanted to be engaged and they wanted their constituents to be more engaged, we asked more pointed questions about what did you need to be more engaged. And overwhelmingly, respondents indicated that more easy to understand information about their particular health conditions was the most popularly rated thing that support people needed to become more engaged in this process. So I think that really supports this conversation that we've had so far today. And then after that, we had the meeting in Anne Arundel, which also was one of the recipients of the Regional Transformation Partnerships with the Bay Area Transformation Partnership. That one was held during the day. And there was also interesting representation from the local area agency on aging and some of the resources that they've already, and kind of systems that they already have in place for facilitating feedback and deeper engagement and referrals across different providers and supporting the needs of particularly the senior populations there that I think apply not just in Anne Arundel and in that region, but across the state that we might want to consider as valuable messengers as well. And we'll reflect that in my comments for both the communications plan and the overall report. But are there any questions? We will be working, special thanks to Tiffany, who presented at the Montgomery County Forum, and Novella, who presented at the Anne Arundel County Forum. If you have any other thoughts you want to share from, they talked about the work that we are doing around this table and on the next steps and the timeline so that folks are more aware of the work that we're doing together and excited about the reports that are coming up and how they might be thought out by hospitals and their providers and the community to become more engaged. But we will be working on our report as well, and hopefully by the end of July it'll be available. Okay.
Any questions? Okay. So there was the consumer outreach and I think it's community outreach and consumer engagement.
Sorry, can I add that there's one remaining forum in Baltimore City on July 7th. All that information is on our website and on the base camp, but it'll be it's the church across from Bon Secours in the evening at 6 o'clock. And really would love everyone to come. If you haven't been already to any of the forums, it'll be a great one. So thanks.
Yep, the consumer outreach and engagement subgroup. Our group hasn't met, but we need to meet soon. We typically have been meeting after forums to review the results from the forum evaluations and then figuring out how we might apply that towards our work. And so our most recent meeting, we did have some feedback actually from this task force and from the subgroup, and we changed one question, right? We had another question. So our the form evaluations are kind of reflective of this evolutionary process that we've been going through, trying to figure out what information will be useful to us, how we will apply that information. And so we have one more forum left to see. But I think that in addition to the information that Linda will bring to us and our review of all of the presentations we've had and the data that we've looked at, and then the form evaluations and feedback from that will really help to inform the strategies in the communication document, also and whatever other recommendations we offer in our report. So we'll have to get another meeting on the calendar. And that group will be looking at, we'll be editing and providing some input to the report that the Consumer Outreach Task Force developed.
Any questions on that? Any public comment from the public? Anybody on the phone that's the public? Have we got anybody left? I know Nicole Stallings was on there. Any input from you folks out there in the cyber world? Nope. Okay. So the next steps for us are to look at the specifics of the strategies and tactics and get any thoughts back on those by close of business on Monday, and then we will get out an agenda for the 10th, the call, which will be primarily to continue to look at those and bring those into some focus. And then we'll just turn it over to Linda. Anything else? That's true. So what we had suggested for the meeting on the 17th was based upon Linda's revising that and tightening up the report. The group would be able to talk about that. We're going through the document that we have now and the newest additions to it, the 10th. Sounds like we got a crowd out there. Okay, well, thank you all very much.